I'm going to ask you to go back. You mentioned briefly, you did a quick spine screen. Um, for those who aren't familiar and who aren't clinicians out there, why in the world would you look at her spine when she clearly told you she got up and had knee pain?
Because the spine is relevant to the knee in many, many cases. So look at the XPOS study, look at how many lower extremity problems are significantly influenced by spinal motion. And if we miss that part, based on that study, I don't have the percentage memorized, but what is it, 40% almost, that we're going to miss relevant findings there that drastically affect the knee.
Okay.
And we're not going to have that ability to improve if we miss those findings.
Okay. And again, for those that aren't familiar, maybe a patient out there or someone who's suffering with knee symptoms is listening to this, what does that spine screen include and how long does it take? And just talk about that for a moment.
So it takes minutes, done well in most cases. In this case, we have major knee baselines. So we set those knee baselines first. Then we look at the spinal motion. So the goal here is to get her to end range. And what typically we look to do is end range extension, and then look in the lateral, posterior lateral compartment as well. So the spine screen in this case was extension and lying. So end range extension of the lumbar spine, adding overpressure, both in the lower lumbar, mid lumbar, lumbar, upper lumbar, and rechecking those knee baselines after each. Nothing changed, so took a quick peek at flexion rotation, both toward and away, and side glide and standing. So now we've looked at all those planes of motion. We've taken her to end range. I'm confident of that. Nothing's affected her knee baselines. I'm done with the spine, maybe 5 minutes. So.
Got it. Okay. All right. So again, she had loss where you assisted her to try to straighten her knee fully, even into hyperextension if it was available. She had considerable loss, observable loss. It hurt probably at end range, I'm sure. Yep. And then you did the same with bending the knee, and the knee also showed a loss of motion and pain. Then you went to the spine and began to hyperextend it from a lying face down position progressively to where you added overpressure with your hands to make sure the joints got all the way through end range. And there was just no change, significant change to the knee motion when you went back and checked that.
Correct.
Along with some rotation, you said, and some side movements. Okay, thanks for doing that. I appreciate you kind of clarifying that. So you saw enough of the knee did change with hyperextending the knee or bending the knee fully after you addressed it with some knee movement. What was the movement that showed to improve her knee range of motion that convinced you, or at least persuaded you it's worth pursuing this?
So really all she did is sitting on the table, actively extending her leg and really trying to facilitate a full-on quad contraction to get to end range. Typically have the patient try very hard to hold that for a 5-second count. So she's really, really working to engage the quad. Probably 10 to 12 repetitions. What happened then, laying back down on the table in supine, prior to doing that, her knee would not even come close to touching the table. I could put my hand under her knee, or between her knee and the table.
Okay.
After doing the extensions, it's laying on the table. There's less pain there. There's a change.
I see. Okay. All right. As Stephen's mentioning this, Mary, do you remember this?
Oh, yeah. Yeah.
Okay. All right. Yeah, you didn't get a great deal of symptom relief that day from what I just heard you mention earlier, but
I think it even felt worse like the next day or two.
Okay,
Sorry.
way to go, Stephen. Nice job.
Yeah.
Yeah.
Comes with the territory, right?
All right. So you had a little increased pain. So why didn't you think, I'm not going back to that guy? He'd built some trust, I guess, huh?
Well, I know that from personal experience and medical experience, sometimes the next day or two is going to be a little bit more painful. And then, it started, the pain was alleviating after, the second day. And
Got it.
so just kind of anticipated it wasn't going to be comfortable. I believe even Steven said to expect it. And so
Yeah.
that's, to
Gotcha.
me, it comes with the territory of physical
Sure.
therapy.
Yeah, and to give the patient a good expectation that, hey, you may feel some symptoms since we're moving this body part, that's already can be upset or angered pretty quickly
Yeah.
was probably pretty important. So certainly we're taught to do that. Hear the entire episode for free on iTunes, Spotify, other favorite podcast players, or go to mechanicalcareforum.com.